Hi, everyone, and welcome back to another episode of the Oncology podcast. My name is Elisa Agostinetto. I'm a medical oncologist at Jules Bordet Institute in Brussels, Belgium. And today I have the pleasure to be here with Dr. Erika Hamilton to talk about a topic that is very important for our daily clinical practice as breast oncologists, namely the management of patients with advanced HER2-positive breast cancer. So first of all, Dr. Hamilton, thank you very much for being here with us today. Would you like to introduce yourself for our audience?
Yeah, absolutely. Thanks for inviting me. I'm Dr. Erika Hamilton. I lead the breast cancer research program at Sarah Cannon Research Institute in Nashville, Tennessee. Happy to join you today.
Thank you so much. So without any further delay, let's dive into the topic of today's discussions, namely the management of patients with advanced HER2-positive breast cancer. And just to give a little bit of context, I would like to do a short recap of what's our standard of care nowadays for HER2-positive advanced breast cancer. So in first line, our standard of care is still represented by what we call the so-called CLEOPATRA regimen, namely this combination of pertuzumab, trastuzumab, and taxane, followed then by a maintenance phase with the trastuzumab, pertuzumab, with or without endocrine therapy in case, of course, of hormone receptor positive status. But at ASCO this year, we saw some very interesting results coming from the Destiny Breast 09 trial. So Destiny Breast 09 was a randomized phase 3 trial that included the patients with HER2-positive advanced breast cancer that didn't receive any prior treatment in systemic treatment in the metastatic setting. And these patients were assigned to one of three treatment arms. So either trastuzumab deruxtecan plus pertuzumab, or trastuzumab deruxtecan plus placebo, or pertuzumab trastuzumab taxane. And the results that we saw at ASCO were actually about the comparison between the trastuzumab, the deruxtecan plus pertuzumab arm versus the CLEOPATRA regimen arm. And actually, we saw this significant improvement in progression-free survival associated with the trastuzumab, the deruxtecan plus pertuzumab. So the first question that I would like to ask you, Dr. Hamilton, is are these results practice changing in your opinion? And if so, do they apply to all patients with advanced HER2-positive breast cancer, or would you consider maybe a selected population to be treated with this regimen among the patients with HER2-positive advanced breast cancer?
I think that was a fantastic summary of where we stand right now. I think that, the magnitude of benefit certainly was quite impressive. I do think these results have the possibility of being practice changing. Certainly, we've seen fantastic data from trastuzumab deruxtecan, not only in HER2 positive disease, but also HER2 low and ultra low. I think your question as to who is a really important one, and I'm not sure that we actually have all the data to answer that question right now. Nobody likes kind of, as I like to call it, naked chemotherapy, but the advantage of the CLEOPATRA regimen is really that we tend to do kind of an induction with the chemotherapy for about 6 to 8 cycles, and then drop the chemotherapy out where patients are just remaining on the antibodies. Now, for patients that are ER positive, we add an endocrine therapy, and then we saw the data from Patina last year at San Antonio Breast showing a benefit of adding palbociclib that was actually pretty large, in my opinion. Now, that's not approved here yet, but I think it's something that we're all kind of thinking about. And so I think the disadvantage of DB09, certainly fantastic data, certainly, PFS, very compelling, is what's going to be the appetite to continue trastuzumab deruxtecan for 3, 4, maybe 5 years for some patients. Certainly, we know that the antibody drug conjugates do tend to be more tolerable for our patients than naked chemo, but compared to a regimen where that chemo is dropped out and patients are just staying on antibodies, I think this question of maintenance is really going to come up, and who is potentially appropriate for kind of, a de-escalation, kind of a induction, and then, potentially dropping out the ADC, and who isn't. And we don't have the answer to that yet.
Yeah, hopefully. I mean, I saw that there is a presentation planned for upcoming ESMO annual meeting that are additional analysis on key subgroups of interest from DESTINY-Breast09. So maybe this could be a presentation that could help get additional information on this topic. But yes, I totally agree with you, and I like the point you raised indeed about these potentially inducing phase and followed by a maintenance phase. There are actually some trials ongoing on this topic, but they are non-randomized. So I was wondering, do you think they would be able to provide enough evidence to change the clinical practice in case, of course, this study will actually demonstrate a benefit?
Yeah, I think that they probably will. I mean, I think it's less of a question of, kind of how long the two PFSs would be, but really just thinking about the fact that our HER2 positive patients, last data have overall survivals in excess of 5 years. And I anticipate that that's actually even improving now. And so we also really need to take into account how our patients are going to do over the long term with treatment for that long. So, if I have to predict a little bit, I've heard some people saying, oh, I'm probably going to do something similar to CLEOPATRA. I'm going to do 6 to 8 cycles and drop it out. In my opinion, I think that may be a mistake. We see about a doubling in the PCR rate with DESTINY-Breast09 compared to the CLEOPATRA regimen. And I think there may be something about these patients that get really deep responses. I think we all have those patients with HER2 positive cancer that are years and years out and kind of have no evidence of disease. And these patients have exceedingly good prognosis. And so I think in the absence of data, if you are going to drop it out, I'm thinking of treating to the maximum response. So that may be longer. That may be 6 months, but it may be 9 months or a year before I think about doing that again, because I want to have my patient get the deepest response they can in that first line setting.
Yeah, absolutely. I think that a personalized approach would be really like the optimal approach in the end. But of course, I agree that we still have many open questions on the data of DB09, and we will see in the next future how these will change actually our standard of care. I have a few more questions for you, and these are more related really to our daily clinical practice and to our daily use of trastuzumab deruxtecan for patients with advanced breast cancer. And the first question that I have, it's really related to safety, because this is, of course, an important topic. And especially we know that one of the severe and potentially also life-threatening complications with the trastuzumab deruxtecan is the possibility to develop this interstitial lung disease. And I wanted to ask you, because, I mean, we know that sometimes there is a bit of a discrepancy in the frequency with which we screen for ILD, namely that we perform a CT scan of the thorax in the clinical trials, and then what is actually done in the daily clinical practice as per standard of care, especially maybe in context also of limited resources. So I wanted to ask you, how often do you actually screen for ILD? Do you prescribe this CT scan of the thorax? And if you have any special recommendations or suggestions for clinical practice in this regard?
Yeah, that's a fantastic question. In the clinical trials, CT scans were done every 6 weeks. And as you bring up, that's really not realistic in the real world. I don't think through insurers, et cetera, we're going to get, CT scans approved over the long term that frequently, not to mention it's a burden on our patients. I typically do try to keep my scans a little closer together than I otherwise would for a therapy that has such a long PFS. I tend to really start with scans every 9 weeks. So every 3 cycles. That gets us over the 2-month mark where I can get the insurer to kind of pay for scans routinely without issues there. I have occasionally moved out to 12 weeks, but I really would not move out longer than that. And again, as you bring up, it's really the importance of finding that ILD when it's grade 1 and the patient can be rechallenged with drug and not have to permanently discontinue. As we know, depending on which study we're looking at, ILD rates with trastuzumab deruxtecan range somewhere between about 10 to 15%. So it's really not that infrequent. It's something that we are going to be dealing with our patients. But again, I want to find it when it's grade 1. I typically actually do start steroids. I stop drug. And then repeat a scan and try to get them back on. But remember that if patients have symptoms, shortness of breath, any hypoxia, cough, etc., that really crosses into the grade 2 threshold where it's not recommended that we rechallenge.
Yes, you mentioned indeed that this grade 1 ILD. That brings me to my next question, because indeed at ASCO this year, we also saw these important results about rechallenging trastuzumab deruxtecan after a grade 1 ILD, and data were overall quite encouraging. So as you said, the rechallenging in this case is possible only after a grade 1 ILD, but not after grade 2 or higher grades ILD, namely when the symptoms occur. And I would like to ask you about your personal experience, if you have ever happened to you to have to rechallenge T-DXd, and for what type of patients, and what was your experience about this?
Yeah, we participated in all the Destiny trials. So we've been using trastuzumab deruxtecan for quite some time. So I have encountered this. I've similarly had a good experience with grade 1 ILD. I have rechallenged multiple patients. I haven't gotten into trouble. Yes, I think a couple of my patients have had a recurrent ILD, but it was not more severe. I've not, knock on wood, had any deaths from trastuzumab deruxtecan. So I do feel very comfortable, if that's caught early, to rechallenge. I think it's also tricky right now because there's so many viral illnesses, respiratory, COVID, etc., that really can mimic ILD in some ways. And it's a shame to have to permanently discontinue a drug that has potentially overall survival benefits for our patients when, it's hard to tell really whether something was related to drug. So yes, have been successful with grade 1. And I've kind of gotten back around to the bias that I just go ahead and treat with steroids for grade 1. I think we can get back on drug quicker, and it really ends up kind of clearing up those CT scans faster than if you just wait with time alone.
And has it ever happened to you to rechallenge when the grade was 2 or higher than 2, or it's something that absolutely you would not recommend as it is in the guidelines and in the recommendations?
You're gonna make me take a stand on this. So I have done this once before. I think that grade 2 ILD is a little bit tricky because grade 2 can encompass a lot. Grade 2 can be somebody that said, oh, well, I typically run 5 miles and I'm finding myself a little bit more winded. Or it can be somebody that actually had a drop in their oxygen in clinic. So I think that there's varying degrees within grade 2 ILD. I have rechallenged for one patient that had very mild grade 2, a little bit of a cough, but otherwise no symptoms. I would not recommend doing that routinely. I think you have to have a very clear discussion with the patient on the risks. This patient was well aware that it could be fatal, but she really was quite heavily pretreated and didn't have many other options and was getting a fantastic response. And so felt very strongly that that was a risk that she was willing to take to keep her cancer under control. I suspect eventually we'll get brave enough to start looking at some of these grade 2s and not saying all grade 2s are equal, but we do not have evidence right now that retreating with grade 2 is safe.
Yes, thank you so much. I think this discussion was really interesting and gave us a lot of insights and tips for our also clinical practice. Do you have any final remarks before we close this podcast?
No, thank you so much for having me. I think that these data moving antibody drug conjugates up into the earlier setting really are quite exciting and present some challenges for us in sequencing and ordering.
Absolutely. Thank you so much, Dr. Hamilton, and thank you all for listening to us.